to Kaieteur Radio every Monday at 1:05 p.m. for your health matters.
Good afternoon, everyone, and warm welcome to Your Health Matters here on Kaieteur Radio. I'm your host, Rihanna Ramsey, and today we will be discussing non-communicable diseases, or NCDs, and we have with us Dr. John Anderson from the Georgetown Public Hospital. He's a general practitioner there. Before we go into our program, I usually give a little brief on what we are talking about. And non-communicable diseases, or non-communicable disease rather, is, as the name suggests, a disease that is not contagious or transferable directly from one person to another. And it accounts for at least 41 million people each year dying worldwide. 71% of all deaths global and 71% of all deaths globally. Each year, more than 15 million people die from NCDs in the region, and they are between the ages of 30 and 69. 85% of these are premature deaths, which occurs in low and middle income countries, and our country would fall in that category. So Dr. Anderson, I know that you give me a little bit of brief about yourself. I know that you're a graduate of the University of Guyana with an associate degree in pharmacy in 2014, but you could just give us a little bit more.
Okay, good afternoon to you online viewers, and thank you, Rihanna. So in addition to working at the Georgetown Public Hospital, I lecture at the Georgetown American University and also at the Guyana, the Georgetown School of Nursing, and also with the Guyana Nursing Council. From time to time, I'll be called to work with some of their students there. So that's a little bit about what I do apart from working at Georgetown Hospital.
Okay. So we're talking about non-communicable diseases, and for those who are listening that don't know what that is, and it seems like a broad term, how do you break it down to them? Because I earlier mentioned that it's non-transferable, but there are certain diseases that fall in that category. So just go ahead and tell them.
Yes, it's certainly a broad term, indeed, and it's designed to cover a wide range of conditions. And so it's a group of conditions, non-communicable diseases, that are not caused by infectious diseases, but they do result in long-term consequences that require a very lengthy period of clinical management. And oftentimes these conditions are lifelong, and apart from being life-threatening, they're lifelong, so that patients are usually engaged in medical care and receiving therapy for a very protracted time.
Yes. And what are can you name some of these diseases, and what are the most common in Guyana? What are we looking at?
Right, certainly. So in Guyana, I guess if you ask anybody, you go down to border market and you say to them, what are the most common diseases, they will shout hypertension and diabetes.
Which is high blood pressure and diabetes.
And high blood pressure and high blood sugar, to put it very simply. cardiovascular disease, which is heart disease, asthma. Those conditions rank among the top 5 in Guyana. Cancers also are right up there, particularly now that we're able to diagnose better. Because before, many persons would have died, and we weren't sure of what their the causative agent for their death would have been. It probably was sometimes a little obscure, but now our capability to diagnose has improved, and because of that, what has resulted is that we can now diagnose better, so we know more, and so cancers fall right into that category as well.
And could you tell us, I know that, I spoke earlier about the amount of the impact, how much people die as a result of non-communicable diseases. What is the impact on our healthcare system? Can you speak to that?
Yes. So there is data available to show that Guyana is basically a young population. We have just close to 50% of the population being young people. And what we're seeing now is that non-communicable diseases are affecting young people increasingly worldwide, and more specifically on the local front. So, and that there are reasons for that, but certainly you find the younger population being affected now more than before, with the consequences following. And if you look at that population and what value they bring, this is the working group of the country. These are the people who are pushing, are the forefront of the developmental thrust of the country. So there is a problem if this group is going to be affected by non-communicable diseases, particularly given the protracted nature and the lifelong consequences of these conditions.
So I'm encouraging those who are viewing via Facebook our live video. You can post your questions if you have any questions.
Sure.
And we'll include them, try to accommodate you. So you were saying that Guyana, we deal a lot with, and a lot of young people are affected now.
Yes.
We deal a lot with hypertension, high blood pressure, as we call it commonly, on blood sugar and heart disease and these kind of illnesses or conditions. What are some preventative measures and treatment so that we can live a long life, not healthy, fully healthy, but at least a quality life, even if we're diagnosed with these conditions?
So, we can talk about preventative measures from a number of perspectives. But within the context of this conversation, what I would say about preventative measures, really education is right up there. The thing is, when you talk with patients, you find that patients don't know. And lack of information is one of the main things that we find as a problem as it relates to non-communicable diseases. So prevention from the perspective of what we can do before one becomes affected by a non-communicable disease involves screening, involves education. And both of those interventions really speak to primary health care, which is that arm of health care that looks for, in a very preemptive way, signs of chronic disease and so on, and basically seek to prevent, and there are ways to prevent. All right. So to tie it in and to really speak to it in the local context, primary health care is where screening lies, is where education lies. And so if you go into communities and you talk to people, as an example, let me say, you go into a community and someone is hypertensive. When you check their family history, their mother and father are hypertensive. And then you begin to go do background checks and you see that there is a family history of hypertension. So not only are you seeing that particular patient, but you are walking back to see the rest of the family, because there is a familial association with hypertension. And therefore, the screening is not limited to the person who comes to the health center or comes to whichever location and is discovered to be hypertensive, the screening goes back into the family. And that goes for every single condition, be it cancers, be it diabetes, be it asthma, be it whatever non-communicable disease you want to pick. Mm-hmm. So that screening is important. And then education. When you tell persons what they can do to prevent and to help their condition, many times they would say, "Doc, I did not know." Mm-hmm. And that is why I'm identifying education and screening as two of the important responses that we should have to, if we want to answer the question of prevention and so on. All right.
You spoke about family history, but there are other risk factors, lifestyle.
Certainly. So we can talk about lifestyle. And so how we like to divide it are patient factors, which are factors that has to do with the patient themselves, and then there are factors outside of the patient that may have to do with access to healthcare, access to good information, access to screening and things like that. So the patient factors, what can the patient do? Many lifestyle practices influence the occurrence of these non-communicable diseases. As an example, tobacco smoke, excessive alcohol use, a sedentary lifestyle. That's how you become obese. All right, and poor diet. These are all lifestyle choices that usually lead to many chronic diseases. And they're very much intertwined. If you want to discuss any one of them, there's a way where they all lead back to some other condition. So, for example, excessive tobacco use does not just affect the lung and cannot only cause chronic obstructive pulmonary disease, which then can lead to right-sided heart failure, and then the person has a problem. But smoking in and of itself damages blood vessels, which then can influence hypertension, kidney disease, brain function, etc., etc. So they all are intertwined.
Yes.
So if you pick any of these lifestyle practices, tobacco use, excessive alcohol use, which can have a deleterious effect on the heart tends to become dilated, then the person begins to get problems, valve issues, and so on and so forth, and the list goes on. They all circle back to kind of touch on each other, if you understand what I'm saying. So that alcohol use can lead to problems that you can also have if you are someone who is smoking tobacco, So all of these practices really, so it couldn't be that you stop drinking alcohol but you're smoking and you're continuing with a sedentary lifestyle, and that's okay. No, there has to be a fixing of everything simultaneously to whatever degree that we can, based on the patient's ability to conform to the commitments that they would have made to change those lifestyles.
That is very, very important when dealing with NCDs. In terms of lifespan, let's talk about that. When somebody has diabetes or hypertension or any one of these diseases, it has the capacity to cut their lifespan short. But they can also live long with the illness or the condition, and based on the way they adapt and monitor. Could you speak to the part where persons have to monitor themselves? Can you talk about that a little bit?
Okay. So just to make sure that we are covering the whole question, the issue of life expectancy in the presence of a chronic disease really is, we use the word mortality. Okay, how does it affect mortality? And then there's another word, morbidity, which speaks to illness, just being sick. All right, but when it comes to mortality or death from chronic diseases, it's not a very simple question to answer. Why do I say that? Because each chronic disease has its own consequences. And those consequences, based on how well they are managed, it influences mortality. But apart from that, there are patient factors that also influences mortality in the presence of chronic diseases, such as your genetic profile. All right, your genetic profile, your environmental exposures, your lifestyle changes that you've been able to make, your commitment to therapy, your adherence to medical advice and things like that. All of those things. So it couldn't be that we have 10 patients and because they are being managed on appropriate medications, they all will have the same lifestyle, life expectancy because they're of the same age. No. Patient 1 may be very adherent, but they may have another issue which may influence their life expectancy. Patient 2 may be very non-adherent to everything, which influences life expectancy as well. But beyond that, the consequences of these conditions, which I'm sure we'll touch on later on, will influence what happens. Whether someone develops renal failure in diabetes or heart failure in hypertension is dependent on how well controlled that person is and what their degree of morbidity was when they started to receive medical care. Because person 1 can come to you after 1 year of being an uncontrolled hypertensive, realizing that everything that they tried didn't work. They would have tried the usual measures that you would hear around. And then it didn't work, and they decide, look, I'm going to go to a doctor because this is not working. Person 2 may say, look, what you don't know don't kill you, and therefore I'm not going anywhere. And they end up with a stroke, or they end up with a heart attack, or they end up with a myocardial infarction, and they turn up to care 5 years later. That's a different patient from the one that I described previously. Right? So in terms of what influences morbidity, it is a multifaceted understanding that we need to have, that this is not just if the patient does this. It's when the patient came to us, what would have been their state upon initiation of medical therapy, how compliant they are, what is their genetic profile, because that also influences how well they respond to medications and so on and so forth and so on. So that covers that. You mentioned something else that I didn't touch on, the other half of the question.
I was talking about monitoring, how that factors in.
So monitoring is a big issue, right? Because first of all, again, the primary healthcare system is in place to do that monitoring, okay? And there are limitations even in the primary healthcare system, so that there are limitations there, and so it puts a strain on the capacity for monitoring. Good. Then there are patient factors, because you would expect that if the health center only has 5 blood pressure monitors and can only monitor 50 patients a day, then you would expect some patients to purchase their own blood pressure monitor. But that's a challenge for a lot of people. They can't afford to buy it. So monitoring in that respect can be limited by financial factors and by the basic capacity, the overstretching of the capacity of the system to deal with the number of patients who may need to be reached. And then lastly, there is the patient who just would not come for any screening or monitoring. Then you have to go to that patient. That's a different dimension then to the reach that you need to be able to effect good monitoring for chronic diseases.
As we're talking about NCDs, and I know that there's a unit set up to deal with specifically all non-communicable diseases. Could you talk about the policy, if there's a policy that guides healthcare workers as it relates to dealing with persons who have been affected or who are diagnosed with any one of these illnesses that fall under the category?
So the Ministry of Health does have an NCD unit, and they have set out policies, broad guidances, which would allow us to understand and approach to patients with chronic, with non-communicable diseases, but specifically in terms of how to manage on the ground. What happens is that for example, within the Department of Internal Medicine, you have different arms. We work in the outpatient chronic disease management unit. That's where the medical clinic comes. And oftentimes we make diagnosis, we admit patients to the ward or to the emergency room, but there's a lot of work that happens there. And within the context of management specifically, what we have done, and that this is throughout the department, both on the ward, in the clinic, and elsewhere, we follow international guidelines. So that there are some known international guidelines that we follow that generally sometimes don't vary very much. But those help us to determine what specific steps to take with patients. That is not to say that the doctor does not have their own clinical judgment to make. Because as I've said to patients on numerous occasions, not every patient who is hypertensive should go on Ramipril. So that the practice of just taking your neighbor's medication and use because it's for hypertension is not necessarily the right thing to do. And I'm saying that to say that we have to make a judgment based on the patient to be able to say this is what this patient needs, and to be able to justify that. So that the NCD arm of the Ministry of Health does not necessarily direct the protocols. Those protocols are done at the hospital level and departmental levels, where you have specialist trained doctors who are able to put together protocols locally from the international guidances that are available. But we have access to this, and we oftentimes use them to guide our practice, and we use what are called physician helps. So we pull up a protocol very quickly if there is a question, and we can get some guidance there. But in general, what the Ministry of Health has done is to set out policies to guide in very broad terms, and also to give us data, epidemiological data. I've looked at the last document that was put out there, and it has a lot of epidemiology to tell us by age, by race, by certain demographics, who is affected by what.
So you have something that is you're basically working on the guidelines.
Yes.
You have something that is guiding you, and you have some some structure to what you're doing, basically.
Yes.
So we're gonna take a short break, and when we come back, we'll talk about the impact of COVID-19, how it's been affecting those affected by NCDs, and how it has been affecting your work in this department, and then we're going to go into some actual specifics.
Sure.
Getting vaccinated is important in protecting yourself and those around you. The COVID-19 vaccine is not a cure. The Ministry of Health's vaccination drive is to remove the virus's ability to cause hospitalization. It helps to look at your exposure to COVID-19 like this. Best case scenario, you don't get infected, and the worst case scenario is death. Get vaccinated today. This is a message from Guyana's Ministry of Health in collaboration with PAHO WHO.
You're constantly exposed to viruses and bacteria every day. That's why you should take Redoxin Double Action. Its formula of vitamin C plus zinc strengthens your body's defenses to fight diseases caused by virus, bacteria, and minor infections. Take Redoxin Double Action every day. It's from Bayer.
Welcome back. You're listening to Your Health Matters here on Kaieteur Radio. I'm your host, Rihanna Ramsey, and we are talking to Dr. John Anderson, and he's telling us a little bit about NCDs, which is non-communicable diseases, and we have been touching on a number of issues as it relates to NCDs. Dr. Anderson, we want to talk about how the impact of COVID-19 and NCDs, because we know that COVID-19 is contagious, but NCDs are not transferable. You don't get it by touching and all of that, but it has an impact. COVID-19 has an impact on those who have these, what you call comorbidities. So talk to us about that.
Yes. So COVID-19, we have to understand what COVID-19 does to the body, and more specifically the immune system. All right. So any viral infection follows a particular immunological pathway.
Yes.
Okay. They enter, they bind, they basically hijack the DNA of the cell, and then they replicate and spread. Now, what it does is that it affects the function of the immune system, in that it basically overwhelms it as against HIV, which knocks out a part of that immune system and make you vulnerable. So the sheer volume of infective material and what it can stimulate, what it can do. All right, those of us who see COVID-19 patients and those of us who have read on the disease will talk about cytokine storm. You have this shower of material that basically stimulates the body to respond, but that response is not nearly adequate. All right, so that your immune system becomes active, but it becomes overwhelmed at the same time by the sheer volume of the infective particles. Now, what it does in the end is that it immunosuppresses the patient, so that the patient's immune system becomes less capable than their pre-COVID state of handling the normal work that the immune system does. And so in the case that there is a patient with diabetes, for example, diabetes itself immunosuppresses the patient. So you can imagine that a patient with uncontrolled diabetes will have a decrease or diminishing of their neutrophil function. And that's one of the reasons that they get infections, so that their neutrophils cannot respond. These are white blood cells that are there to kill bacteria and so on. Those cells cannot function the way they ought to function in the presence of uncontrolled diabetes. And then you superimpose or you add COVID on top of that. Those patients tend to decline pretty quickly, particularly if they're uncontrolled. And if they were uncontrolled for a long time before, then their immune function would have been subpar a long time. And then when you add COVID on top of that, that was just the nail in the coffin, to put it that way. And so it's just to paint a picture that COVID-19, and of course COVID-19 doesn't just affect the immune system, but there's a multi-systemic effect from the brain all the way down, so that persons develop psychiatric illnesses. Some persons even those who recover, will recover with lung issues, fibrosis in the lung, healing with scarring in the lung, and those people can have a long-term lung issues and so on and so forth. So that when we're talking about what COVID-19 does to people with comorbidities, all of these non-communicable diseases are comorbidities. It basically exacerbates the process and makes that condition do more to the patient in that moment than it would have done throughout probably the entire life.
And as we were talking, that's a bit it's hard to swallow, but I guess people need to know, because even though we hear it all the time, we never really get to understand. So thank you for explaining what that does. As we are on the topic of these specific types of diseases that fall or conditions that fall under the category of NCDs, we're going to talk about diabetes. November 14 was World Diabetes Day, and we had a show ahead of it, and we discussed a lot about diabetes, and a lot of people message and sent private messages and so on concerning the show. They were very they liked it because a lot of people in Guyana deal with blood sugar.
Oh, yes.
And so we're going to talk about blood sugar. Let's talk about diabetes for a bit. And I know that you've been a doctor practicing for some time now. Tell us some of your experience when it comes to treating patients with diabetes.
Okay, so the experience.
When I mean experience, I mean like common traits. Like what do you find? Are they cooperative? Are they more? What do you find with them?
Right. So I was going to say the experience can be divided up into several categories, right? Some that have to do with the patient factors, some that has to do with the effect of the medication, some that have to do with the effect of the system that we have put in place. But I think what you want is basically those cultural issues that we see coming to the fore when we see patients with diabetes.
Yes.
All right. Now, we in Guyana, as with every other country in the world, have certain local taboos, not taboos, but certain local beliefs that will influence how we treat with health and everything else. Diabetics in Guyana, many of them think that, they can use a bush, some kind of a herb. If they use the herb, and if it's a bitter herb, that herb will, once it gets into the system, all right, remember they're drinking or so on, this substance, it goes into the gastrointestinal tract. Some of it is absorbed, some of the constituents are absorbed, and the rest is excreted. But to their minds, this entire bulk of substance is finding its way into the bloodstream, and bitter counteracts sweet.
Yes.
So naturally, once that bitter substance gets into the blood, then it deals with the sweet and you have no other problem.
Yes, I've heard people say it.
But that is not scientifically sound. Because the problem that you have with diabetes is that you have either insulin resistance, which is you are making insulin, but your cells that are supposed to receive this insulin and act on the instruction that insulin normally gives, those cells are resistant to insulin.
Yes.
Or your pancreas is making an inadequate amount of insulin.
And insulin, for those who don't know, insulin is the chemical or the mechanism that helps to control your blood sugar level to a point that it's healthy for you.
Yes.
So that when you eat your food, what the system, it goes through the digestive system and it breaks down. That is like a safeguard against the amounts.
So
it's like a
insulin
filter.
moves the glucose from in the blood into storage areas, like into the muscle
where it's needed.
All right. So it means that your pancreas, the gland that makes, the organ that makes insulin, is not working well. And in the case of type 1 diabetics, their insulin production is none to negligible. So they need insulin for the rest of their lives. Okay? So when people take a very simplistic understanding or view of diabetes, which means that you just drink some bitters, it is not so easily fixed. If that was the case, every diabetic would have been well controlled by now.
Yeah.
Right? And so, again, as I said earlier, education is important, because clearly there is misinformation and there are people capitalizing on this misinformation. They make a living off of this misinformation. And it's because they themselves are misinformed.
Yeah.
And that is why I said earlier that education is important. So that's one of the things. Patients will have these beliefs that you can drink a bush and it will take care of the problem. All right.
That's your experience.
That is yes, that is one of the experiences. All right. There are others, but we only have an hour.
Yes. So let's move on. Well, we're talking about diabetes, and let me just ask this one more question on this issue. People don't understand how common it is that people with diabetes, uncontrolled diabetes, and that's an NCD, it's a non-communicable disease, and we're on that topic, how much when they don't control it, it can lead to loss of eyesight, which is diabetic retinopathy, or you want to pronounce it that way, or you can lose your limb, amputation. And tell us just a little bit, just touch on it a bit, and then we'll move on, because we have a lot to talk about.
Right. So very quickly, diabetes has acute and chronic complications. So acute complications are the ones that take you to the emergency room, and sometimes that can cause death. The chronic complications are the ones that you're talking about: diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. Basically, diabetes affecting the eyes, the kidneys, and the nervous system.
Yes.
And without spending too long on it, I want to say that persons need to be educated to the severe consequences of long-term consequences of diabetes. Let's just take the kidney disease. When a patient who's diabetic develops kidney disease, means they become they have chronic kidney disease. That alone has so many bad effects that managing that and managing the diabetes becomes a very burdensome thing, because when you have chronic kidney disease, it affects your ability to produce red blood cells, so you become a chronic anemic. Chronic anemia has its own list of problems that it causes. We have renal osteodystrophy, or renal bone disease, chronic disease causing bone disease, something that is similar to arthritis. And those patients can end up with fractures and breaks, and that brings its own problems. And so on and so forth. So when you look at what diabetes can do to different systems, then you understand that if you develop chronic kidney disease, as an example, then you have a number of problems to deal with, and that alone decreases your life expectancy.
We talk about diabetes. Now we're going to touch on high blood pressure. You touched on that earlier. Who is at risk of high blood pressure? Not just persons who have that, family history, but there are some other people who fall in that category.
Yeah.
Talk about that.
So hypertension or high blood pressure can either be essential hypertension, which is hypertension that we don't know the cause of, right? And that's the majority of patients. And then you have secondary hypertension, which has a list of, there are many conditions that can lead to hypertension so there are secondary causes of hypertension. All right. So persons may come in with endocrine disorders, a number of which can cause hypertension. I mean, I wouldn't go into the individual ones now, but unless you want me to.
No.
But those things can cause hypertension. There are medications that can cause hypertension. Very commonly, drugs that we classify as non-steroidal anti-inflammatory drugs, like diclofenac, ibuprofen, indomethacin, acetylclofenac, and a list of drugs that we buy over the counter in Guyana.
And they can cause
high blood pressure. All right? And a number of other medications that people will buy. They will buy steroids, they will buy prednisolone because they have a knee pain. But then, while it can help with your knee pain, depending on what kind of pain it is, it can induce hypertension. It can induce diabetes, secondary diabetes. So you have those factors there that can lead to. So hypertension, like I said, most of our patients are the essential hypertensive who we don't know what the cause is, but many of them we do know what the cause is, and we have to look for those causes and treat the cause to fix the problem. All right? Well, I hope I answered you.
Yeah,
okay.
Yes, you did. Heart disease is another one, and this is not widely discussed because people don't realize that a lot of people suffer from heart issues.
Yes, certainly.
Could you say what are some of the main causes of having that complication?
All right. So what I want to say to sort of lead us into this aspect of the discussion is to say that heart disease, cardiovascular disease, we use the word cardiovascular, but heart disease is the leading cause of death in Guyana. And that is something that needs to be stated up front. All right? Along with stroke and ischemic heart disease, which is decreased blood flow to the heart that usually causes the chest pain, those account for 28% of the total deaths in our country.
Wow.
So it's important to state those 8%.
Wow.
Right? It's important to state that up front. Now, heart disease, it's very variable. It's a broad term, just like non-communicable diseases. It's a broad term. So you have heart disease that has to do with the structure of the heart itself, because there is decreased blood flow. Why? Because cholesterol goes in there and blocks those arteries, and the heart suffers. That part of the heart that blood vessel is leading to begins to malfunction. It doesn't do its job properly because it's getting less nutrients. And if things progress, you can actually have a heart attack where that part dies.
Wow.
Good. Or you can have issues with the valves in the heart, which may have to do with pressure and volume, how much pressure your heart has to exert because you're hypertensive, so that the blood vessels are squeezing down and your heart is squeezing back. But your heart now suffers as a result.
Yes.
So you can have heart muscle disease, you can have heart valve disease. When the valves aren't working well, fluid doesn't flow where it's supposed to flow. And when that happens, you start to have shortness of breath. You can't climb stairs anymore. You have to lie down on 3-4 pillows. You jump out of your bed panting for breath. Your legs start to swell and things like that. Okay, and then you have diseases affecting the nervous system, the part that deals with your heart, that gives direction and so on to your heart, because that part of your system make sure that the right one pumps at the right time.
Yes.
And the other one relaxes when it's supposed to, so that blood can flow. But if the nervous system that influences the heart is affected, then your heart starts to pump in a way that is not the norm. And many people can eventually end up having clots in the heart, because one part of the heart is pumping and the other one is just there, not doing much. And so once blood is not moving, it has a tendency to clot. And if you have clots there, those clots can move too and go anywhere they want to go, to the brain,
and
to
they
the
could
gut,
cause a stroke.
and they can cause a stroke. So when you're talking about heart disease, there are so many different aspects of the heart that can become diseased as a result of chronic disease, non-communicable diseases, notably and notoriously hypertension.
Yes.
All right?
Yes.
So that, it is important to have a global understanding
Yes.
of what diseases can happen. And so with respect to the symptoms persons will feel, for example, if someone has heart failure,
Yes.
heart failure means the heart is not pumping forward well, or it's not relaxing to receive blood well. And so if blood is not going forward, where is it going? It has to go somewhere. Okay? And so you find that there's leakage of fluid into the lung and you start to have shortness of breath.
Wow.
You used to be able to climb 5, 10, 15 flights of stairs, no problem, run up the stairs, come down back. Now you can't do that. You have to stop several times to catch your breath.
Wow.
Or you have to prop yourself up with several pillows because you're having shortness of breath. Or you jump out of bed feeling short of breath. You have to put on the fan or open the window and sit for about half an hour before you can catch your breath.
And those are symptoms, actually.
Those are symptoms, right? Leg swelling can happen, and chest pain can happen if you have decreased blood flow to the heart because cholesterol plaques have deposited themselves within the arteries that supply your heart. So when that happens, decreased blood flow also happens because you have now something occluding the blood vessel. So blood can't get to the heart as it ought to. And therefore, when you try to do an activity that you used to do, you find you're getting chest pain or you find that you're becoming short of breath. But the caveat to that, or something that is different, is that with diabetics, because they can have nervous system disease or neuropathy, they don't always feel that chest pain.
Yes.
So a diabetic may be having a heart attack but doesn't clutch their chest and cry out for pain. They may just say, look, I'm not feeling well, I'm feeling upset, I'm feeling sick. But they don't know it's a heart attack because the nervous system that surrounds the heart is damaged. And so they're just there having a heart attack and don't know it.
And a heart attack doesn't come on just suddenly in heart
Well,
attack.
actually, it does come on suddenly.
Well,
the symptom just come on a sudden chest pain.
okay.
That may be precipitated by an activity that you were doing,
Okay.
right? But that blockage can happen suddenly.
So, because I was going to ask gradually, because you said the person doesn't know they're having a heart attack because
A diabetic.
Yeah, a
Diabetic.
Okay.
Uncontrolled diabetics, more
Okay.
specifically. But with the heart attack, because of how it happens, it comes on suddenly.
But there are certain things leading up to that, I'm sure.
You would have been getting symptoms before. If you are non-diabetic and you're able to feel that pain, you will be getting some chest discomfort. You may be getting some chest tightness. You may get frank pain in the chest that we call angina. And so those are warning signs. Those are troubling signs that you have a problem with blood flow to your heart. When that blood vessel becomes completely blocked, you get an excruciating pain that we describe as the feeling of impending doom. You know you will die. You know if something doesn't happen, you will die. That patient in that moment
They know.
knows that they will die if something doesn't happen. And so we call that the feeling of impending doom. This is going to happen. And so so those are the varying symptoms that patients can experience that would tell us that there is heart disease there.
You talked about the build up to a stroke, hypertension, then you have heart issues because you can get hypertension and it could go straight into full-blown stroke. But
It follows a particular process, but in general, the presence of cholesterol plaques within blood vessels kind of walk very closely with hypertension and diabetes. So we have to look for that. Okay? And it influences your stroke risk to some degree. So that what happens is that you have these plaques of cholesterol, if you can think about it, just sitting within the walls of the blood vessels. But these plaques of cholesterol are very, they can easily rupture,
yes,
to put it that way. And the blood vessels beneath can bleed. And when that bleeding occurs and a clot is formed, it completely occludes the blood vessel and prevents further blood flow to a part of the brain that may control speech or movement or vision or breathing, so that you can have a blood clot forming in a vessel where there is cholesterol plaque sitting there. And that is why we check your total cholesterol and we check the other components of the lipid profile to see what is happening. All right. Of course, we did say that a stroke can occur because a blood clot comes from a different place in the heart, because hypertension damaged the heart in such a way that clots are forming in the heart because the heart is just not doing what it's supposed to do, and that clot moves to the brain and blocks that blood vessel.
and in terms of identifying early symptoms of a stroke, could you tell us what are some of those?
So, a stroke is not just the event. Well, it's really the event, but there are other associations. For example, some patients can develop what we call a transient ischemic attack. They have a stroke that improves within a 24-hour period. And that in of itself predicts the occurrence of a full-blown stroke within a 30-day period.
Wow.
So that you can have a feeling of numbness or loss of function in half of your body. You may feel numbness to the face on one side, or you may lose complete sensation on that one side, or you may lose complete motor function. You begin to drool on one side, the face droops, that hand, you can't use the muscles of that hand and the muscles of the lower limb of that one side of the body. But then you come to the hospital, we give you some medication, we lower the blood pressure, we put you on some stuff, and you go home and you feel better within 24 hours. But that does not mean, that is basically signaling that coming up next
Is the actual
is the full thing. So in that way, persons who develop a transient, which is a short-term, short-lived ischemic attack, decreased blood flow, that's why we use the word ischemia to describe decreased blood flow, that can last for a short period of time and get better and you're back to normal. And persons can feel that, well, I'm good to go. No need to control my blood pressure, no need to decrease my salt intake, no need to stop smoking, no need to decrease my alcohol intake. I can go back to life as normal.
No.
And when they do that, the next thing that happens is not something nice, which relates into a stroke, which is that complete occlusion of a blood vessel.
My God.
All right? So, yeah.
And do persons, what would you recommend for somebody who has that, is in a condition and may think, okay, I'm good, I can go back to normal? What do you recommend? How would you help that person realize that, no, you're not good, you gotta...
So we come back to education, right? But first off, if you are feeling these symptoms, go to the emergency room. People have this thing, they say you put a nutmeg in your mouth. It is the worst thing that you can do. Because if a stroke affects the muscles of swallowing,
Yes.
and you put a nutmeg in the mouth and it slips into the airway, you are dead.
Yes.
Unless there is someone with medical experience there at the moment to dislodge that, you are going to die by the time you reach the emergency room.
Yes.
So this idea of putting a nutmeg, I had patients come to me with nutmeg in the mouth, and I couldn't understand. I knew what they were trying to do, but to my mind, it really was a dangerous practice. And I've known persons who died because that object became a foreign body lodged in the airway, and they basically suffocated and died, strangled and died. So the first thing is, if you know that you're hypertensive and you start to feel symptoms of numbness to an entire side of the body or the face, it begins with the face many times, or you lose the ability to speak, or you begin to drool on one side of the face because you lose the power in those facial muscles, it is time to head to the hospital. Don't wait to find out and to try some home remedy. Go to the ER. And then from there, after emergency care, then you move on to chronic disease management, where we will do the counseling, we would put you on long-term medication, we will do the screening and things like that. Be it at your health center or be it at the internal medicine follow-up clinic that we run. Be it there or out in the community, you want to be able to access medical care. And this is not you go to care for a few mornings, as Guyanese would say, and then you stop.
That is the danger.
No, because if you are not being cared for, then you don't know what your status is. And when something happens, there's nobody looking.
True.
Right? Which leaves the patient open.
True.
All right?
Open danger.
Yeah.
Okay. So I just before we leave, I just ask you to just recap what are non-communicable diseases and how we can manage and how important education is, and just adhering to what your doctor tells you, because a lot of times we as Guyanese, we have a culture as once we think we're good, we just stop following the doctor's orders, and then we can end up in a worse place.
Yeah. So again, non-communicable diseases are a very broad group of conditions that are not mainly caused by infection or an infectious agent, but they result in long-term health consequences that require you to be in care, sometimes for the rest of your life. How do we prevent non-communicable diseases? First of all, it starts with the person, with the individual. You reach out for help. you reach out for guidance and you seek out a healthcare professional who can give you that education, which has a lot of value. All right, because in Guyana we would say, person would say, if maybe no.
Yeah.
What that means that I did not have the requisite education on this matter. So seek out that education. And secondly, if your doctor gives you a particular guidance and puts you on a particular therapeutic regimen, follow that regimen. Now, if you go on Google and you read something and it says you're going to die tomorrow,
Google.
talk with your doctor first before you decide
Yep.
to act on your own.
Yep.
So adhere to medical advice, medical guidance, and also take personal responsibility for your medical condition. Take responsibility and become part of the healthcare team. You, the patient, should be the chief person, within the healthcare team. You should be the one saying, Doc, I heard about this, I read about this. What do you think? I'm using my medication every day. Should I also stop using salt? Should I decrease my salt intake? Should I stop using certain carbohydrates? I like this. What do you think about that? And start leading the conversation so that your doctor's life is easier or harder, because you may ask so many questions that they have to go to research. But the point is that you are finding out.
Yes.
We shouldn't be chasing you down, even though if we have to, I think it's necessary we do. But you want the patient to lead that conversation. So I think those are things that we should do if we have a non-communicable disease. And from the healthcare perspective, from the healthcare system side, we need to do education, we need to do screening, and we need to ensure that we establish sound therapeutic regimens following guidelines, international guidelines, so that our patients can get the best out of interaction with us.
Well, that's a wrap for today. Thank you so much, Dr. Anderson. We went over a minute over our hour here on Kaieteur Radio. Thank you for tuning in, all those who join us via Facebook or via radio. Thank you so much for listening. We were talking about NCDs, and we hope you gathered some information that can help you better treat yourself. Just be safe until we meet again next week. Thank you for listening.
Thanks for having me.
You're constantly exposed to viruses and bacteria every day.